Hello, I'm Dr. Renee Gonzalez. I'm a board-certified anesthesiologist. I was formerly an associate professor of anesthesiology and critical care medicine at the University of Pittsburgh, and I currently practice anesthesia in New Jersey. I'd like to invite you to consider today a very serious topic. A simple new method for reducing the risk of COVID-19 transmission to healthcare workers during intubation and extubation by using surgical smoke evacuators. Anesthesia and OR staff are and will continue to be at the very front lines of the war against the COVID-19 pandemic. It's well established that so-called aerosolizing airway and respiratory procedures, such as endotracheal intubation and extubation, place anesthesia and OR staff at greater risk of being infected with SARS-CoV-2 virus. This is especially the case during and after prolonged or difficult intubations and extubations. Here's an illustration of what happens when a patient infected with COVID-19 coughs, sneezes, or even exhales, generating an invisible cloud of aerosolized droplets and particles, which can carry coronavirus and lingers in the immediate environment and then slowly spreads, landing on nearby surfaces such as OR or anesthesia equipment, IV poles, sheets, stethoscopes, cell phones, or computer keyboards, where it can survive for hours or even days. And unfortunately, anesthesia personnel cannot practice social distancing from our patient in the operating room. So we rely on a few layers of protection. First, screening and testing. Second, personal protective equipment. And third, the OR room ventilation system. But unfortunately, all of these layers of protection have significant limitations. First of all, according to a very recent statement by the American Society of Anesthesiologists, SARS-CoV-2 testing has a false negative rate of 10 to 30%. We've also seen the nearly weekly newspaper reports about the low-quality N95 masks, so-called counterfeit masks, that are infiltrating the U.S. supply. But here's some good news. What if there already exists a valuable tool to further protect staff and patients from aerosolized or airborne coronavirus? And what if this tool is already sitting in our operating rooms, under-recognized and underutilized? What if it required no capital expenditure? What if it was already FDA approved, easy to use, and based on the well-established respiratory isolation principles of negative ventilation and source control? The good news is that this tool already exists in the form of surgical smoke evacuators. Surgical smoke evacuators have been used for decades. Here are the specs. They provide a very high suction flow of greater than 25 cubic feet per minute, which is about 30 to 50 times more suction flow than a standard Yankow or wall suction. And secondly, they contain something known as an ultra-low particle air filter, or ULPA, which are much more effective than high-efficiency particle filters, or HEPAs. Comparison of ULPA versus HEPA filters demonstrates that HEPA filters are 99.97% effective at the removal of particles 0.3 microns or larger in diameter, whereas ULPA filters are 99.99% effective in removing particles of 0.12 microns or larger, And it should be noted of great importance that the coronavirus is only approximately 0.12 microns in diameter. The Association of Operating Room Nurses, AORN, has for decades advocated the routine use of surgical smoke evacuators for all smoke and aerosol generating surgical cases to improve the quality of air in the operating room and to protect the health of our OR personnel. Surgical smoke evacuators can also be used as a method for reducing risk to healthcare workers of COVID-19 during endotracheal and intubation and extubation. It's a little known fact that surgical smoke evacuators are widely available in many operating rooms across the nation and across the world. For example, all Neptune surgical blood and fluid suction units that we have in the operating rooms at my institution also contain a built-in smoke evacuator with an ULPA filter. Here's a simple sketch of how a surgical smoke evacuator can be used to divert the patient cough and aerosol cloud away from the intubating personnel at the head of the bed and to capture it safely in the smoke evacuator. The concept is pretty simple. Simply hold or tape the end of the smoke evacuator's hose on the patient's chest, right under the patient's chin, near the patient's airway, during intubation and extubation to divert much of the aerosolized respiratory cloud away from the persons managing the airway and to draw it instead into the smoke evacuator where it's safely captured by the smoke evacuator's ULPA filter. What this does is essentially create a personalized negative pressure respiratory isolation room for that individual patient. For a more cost-effective use of the smoke evacuator, it can be shared between anesthesia and the rest of the surgical team. During induction, it's placed near the patient's airway to be used by the anesthesia team. Then during the case, the smoke evacuator is used by the surgical team, and at the end of the case, prior to emergence, the smoke evacuator is given back to the anesthesia team. And for even more effectiveness, a clear plastic intubation extubation tent with a surgical smoke evacuator taped to the patient's chest underneath the tent can be used in combination. Thus further reducing the risk of COVID-19 transmission during intubation and extubation. Thus, there are many pros to the use of surgical smoke evacuators near the patient's airway during intubation and extubation. First of all, it provides additional safety to our healthcare workers, anesthesia, operating room staff, and cleanup crew, and to subsequent patients. Secondly, there's no capital investment. These smoke evacuators are already present, paid for, and FDA approved. In fact, this would be maximizing utilization of an existing capital item. There is not much downside to the use of surgical smoke evacuators. In a recent bulletin on COVID-19 released by the Society of American Gastrointestinal and Endoscopic Surgeons, or SAGES, they warned that since COVID-19 virus has been found in the entire GI tract and in blood, bile, and feces, that there exists the potential of aerosolization of the virus during surgery by electrocautery into the operating room environment. As a result, SAGES went on to recommend that currently the best practice for mitigating possible infectious transmission during open and laparoscopic surgical procedures is to use a multifaceted approach, which includes 1, proper operating room filtration and ventilation, 2, appropriate personal protective equipment, and 3, surgical smoke evacuation. I believe that we as anesthesiologists, knowing that intubation and extubation do contaminate the operating room environment with aerosolized droplets, should adopt a position and practice similar to that being recommended by our GI surgery colleagues. I encourage you to learn more about surgical smoke evacuators, and please be smart, stay alert, and don't be a victim. Thank you.